Hello, everyone, and thank you for joining us. This is Dave Iverson, the contributing editor at the Michael J. Fox Foundation and the moderator for today's Third Thursday webinar on depression and anxiety in Parkinson's disease. As always, just a reminder that you can log in every third Thursday of the month at 12 Eastern, 11 Central, 10 Mountain, and 9 Pacific to hear a discussion about important topics within Parkinson's disease. So we hope you'll continue to mark your calendars each month and join us. And a reminder, too, that if you can't join us live, you can always take in our webinars on demand whenever is convenient for you. As always, you'll be able to submit your questions throughout the hour, which our panelists will take on in about a half an hour or so. You'll see the Q&A box near the middle of the screen, so just type in your questions there, and as always, we'll do the best we can to answer as many of those questions in the second half of today's webinar. The slides from today's session are also available for download, so you can do that by going to the box called Resource List on your screen. If you click there, then the document will open up in a new browser window, and you'll be able to save the slides or print them from there. All right, let's get started with our topic for today. Well, our slides are not advancing, so I'm going to ask my colleague to go ahead and advance the slides if she might. Thank you, Maggie. Here's the topics that we're going to be covering today. We're going to talk some about depression and anxiety and whether they're actually symptoms of Parkinson's disease. It's obviously understandable that you could feel down or depressed after getting that diagnosis, but what does it actually have to do with the disease itself? We'll be digging into that. We're going to talk about what the signs of depression and anxiety are, of course. We'll also talk about whether or not there are some biochemical and biological changes going on in the brain because of Parkinson's disease and how that connects to symptoms of anxiety and depression. We'll, of course, be talking about how these symptoms can be treated. Then we'll talk some about new advances that are going on in the research world, and then talk just more generally about what people with depression and anxiety can do, as well as their family members. So let's go forward and meet who's going to be participating in our discussion today. Joining us are Israel Robledo. Israel is from Midland, Texas. He was diagnosed with Parkinson's in 2007 at the age of 42. Israel is a special ed teacher and an elementary school reading specialist. He's been very active in the public policy arena with Parkinson's disease, also with advocating participation in research, and is a colleague of mine on the Michael J. Fox Foundation Patient Council. Israel, it's always a great pleasure to be talking with you, and thanks for participating in our conversation today.
Thank you, Dave. It's good to be here. Thanks.
Thank you. Joining us, too, is Dr. Laura Marsh. Dr. Marsh is the Executive Director of Mental Health Services at the Veterans Affairs Medical Center in Houston, Texas, where she's also a professor of psychiatry at Baylor College of Medicine. Dr. Marsh, thanks for being part of our discussion today as well.
Thank you. Pleasure to be here.
And joining us as well is Dr. Gregory Pontone. He's the director of the Parkinson's Neuropsychiatry Clinical Program at Johns Hopkins University School of Medicine, where he's also an assistant professor, and that is, of course, in Baltimore, Maryland. Dr. Pontone, thanks for being with us, too.
Thanks for having me.
All right, let's get started with our conversation. And we want to first talk a little bit about the prevalence of depression and anxiety within Parkinson's disease and how often that takes place. So let's begin by talking about that prevalence question first, Dr. Marsh, and then we'll talk a little bit about whether or not it's because you're down or whether or not it's actually something going on inside the brain. But Dr. Marsh, on its prevalence, we see from these statistics how common it appears to be.
Yes, it is. Parkinson's can be complicated by depression, and up to 50 to 60% of people who have the illness. And I think what that's always the question, is it my Parkinson's that's caused me to feel depressed? But when we look at the epidemiologic studies, up to about half of those with depression actually develop their first depressive episode within 5 to 10 years before the onset of Parkinson's, and some people have longer standing histories of depressive disorders. So I think it's pretty clear to say that if you have it before you actually know you have Parkinson's disease, so before you have motor symptoms of the disease, you can't really attribute it to your emotional reaction to the disorder itself. And so we know that depression is associated with brain changes, and there are brain changes in Parkinson's that affect mood regulation, and presumably those areas of the brain are affected in some individuals before the motor areas are affected. And so you can have the condition before the onset of your diagnosis of Parkinson's disease.
That's a really good point. We'll talk a bit later about some of the specific neurotransmitters that are involved and why it may be that Parkinson's disease impacts neurotransmitters that are involved with mood and various aspects of mental health. Before we get into all that too, though, let's talk a little bit about how these two experiences of depression and anxiety go hand in hand. And Dr. Ponton, comment on that some. I think of this at least as that depression and anxiety seem like somewhat different conditions, but we see them in Parkinson's that there's a lot of overlap. Can you describe that and whether or not and why it may be that they so often coexist?
Yes, the co-occurrence of anxiety and depression is common not only in Parkinson's disease, but in the general population. It may be that they share some of the same biological underpinnings in terms of maybe neurotransmitters or even brain regions that cause the symptoms. So, for instance, with depression, we know that brain chemicals such as serotonin, norepinephrine, and even dopamine are important for the regulation of mood. And it turns out that those same chemicals are important for anxiety. So that might be one reason for the overlap.
And we also see at the bottom of the screen that they sort of come and go. Has that been your experience as a clinician? In a moment, we'll hear Israel Robledo's first-person story, but that one might sort of be the more dominant feature for a while, and then it recedes, and the other might turn up. How does that take place?
Yeah, most depressive illnesses are episodic, going on for months or weeks and then resolving either with treatment or spontaneously. In Parkinson's, at least, the most common type of anxiety is a persistent sort of generalized anxiety that might be a little more long-standing. But there are also episodic anxiety disorders. So it really varies a bit from individual to individual. But certainly there's often a trend that when the depression is active, the anxiety is also worsened.
All right. Well, let's get to an individual story and bring Israel Robledo into our conversation. As we go through your story, Israel, we have up on the screen some of the symptoms of depression and anxiety, and you see that lengthy list down both columns of the slide that's currently on the screen. But as a way of making this more personal, it would be, I think, really helpful for everyone participating today to get a sense of how that played out for you. Again, you were diagnosed at a young age, the age of 42. So take us back in time, if you would, Israel, a bit first in terms of what happened, not only perhaps at the time of the diagnosis, but perhaps, as Dr. Marsh was suggesting, even prior to diagnosis, as far as your own experience with depression and anxiety.
Absolutely. Yes, my situation was that I experienced depression for about 20 years off and on before my motor symptoms developed. But what I found with my situation were any prescribed medications for depression were not effective. Never could figure that out. Now, when I my motor symptoms started with Parkinson's, I was about 37, and the depression really started hitting much harder during those 5 years. And it's very true, it was off and on. But with my diagnosis at 42, I kept thinking, I'm too young to have this, and which for most of us, that's usually what we say. But the depression really hit a low point, and it was to the point where I was projecting the disease progression and trying to figure out where I was heading as far as mentally with the depression. And I've often shared I was suicidal at that point because I kept thinking I'm depressed as a result of Parkinson's, and I'm depressed as part of the disease itself. So that's kind of been my background. It's been an off and on. And speaking of anxiety, it's very true to form for myself. Right after diagnosis, the anxiety was very, very high as far as trying to figure out what I needed to do and not knowing how to express myself. I felt so helpless in those situations. So, yes, very much hand in hand did they come with my diagnosis.
And Israel, as you look at some of these symptoms, let's look on the sort of depression symptoms that are on the slide. You've expressed already that there was intense enough that ending your own life was something that you contemplated. I know this is a difficult to discuss, but can you give us some sense of what it was that you were feeling that pushed you to those thoughts? Was it a sense of not feeling worthwhile? Describe a little bit of what you were feeling, and then let's talk some about how you've been able to rebound.
Absolutely. In what I was experiencing, and this is something that I've often shared, is when I was going through the depressive states, I've often said that I'm tired, not physically. It's a mental tiredness that the thinking it's almost like it gains speed. So that is as a little bit of background. In my situation, what I was doing was I was feeling helpless, meaning that I didn't feel that there was anything that could help my situation. I was feeling hopeless because there was nothing that I could do personally to make it any better, no matter what type of activities I found myself doing. And also the simple fact that I was just not understanding why people around me were so happy and they were enjoying each other's company when I was in my own mind thinking, why am I not experiencing that when the world around me seems normal? And I'm trying to figure out why we're not connecting. We're not on the same page. So it goes into a next phase for me where it was more rationalization, trying to figure out why am I even bothering to be here, because I'm not enjoying myself, I'm not enjoying life, and I'm not enjoying what it means to have a quality of life that's good.
And we'll talk more in a little bit about some of the treatment options, but can you, at this point at least, Israel, identify for us what it was that allowed you to begin to climb back a bit? Was it being able to talk to your movement disorder specialist, family members, to begin a treatment regimen that was effective? Can you, as you look back, identify a point at which things started changing a bit on the upward swing?
Yes. Through the years, I had been on several antidepressants, and I came to find out that none of them actually had any effect on my depression until I spoke to my movement disorder specialist, and I said, I'm really struggling with depression. And he prescribed one that I'm on now, and I've been on it for a little over 6 years. And having seen the utter failure of the other prescriptions, this one literally turned my nights into day, and there was a change in my attitude and my view on things that were happening that I could get involved in and actually have make a difference in. So along with what I've often said is much prayer from family and friends and much support, my situation, when I dealt with people saying, you shouldn't be feeling this way, you shouldn't, you've got so much going for you, those are things that as a person dealing with depression, I did not care to hear, because it was, we to a person, we don't want to feel like we're worthless and it's hopeless and we have nothing to live for. So those were very difficult things to try to come to terms with when people are trying to help, but in many ways they kind of make things worse. So, and then we'll talk a little bit more about this later in the webinar, but I would say to a person, be there for the person that's dealing with depression, but don't try to fix things for them. Be there as their support.
Israel, thank you. And Israel Robledo will, of course, continue to participate in their discussion as we go forward. It adds so much to have you as part of this, Israel. Let's get a few more comments, though, now from Drs. Marsh and Pontone about these the symptoms that we're seeing outlined on the screen. And your reaction, if you would. Let's start with this, Dr. Marsh, to Israel's story. I'm sure it sounded very familiar to you, and I know you know Israel from other conversations you've had in the past. But what stands out to you about Israel's story? What do you think is worth underlying about how it may represent the kinds of experiences that people have?
Yes, well, he does a very nice job of describing the quality of a whole change in one's mindset that occurs when someone has a mood disorder. Sometimes depression has been described as looking at the world through mud-colored glasses. And then, of course, as you start to feel better, you begin to, the grass becomes greener and so forth. So depression as an illness, it changes, your view, your perspective on life. And so the feelings of helplessness and hopelessness, which are so profound and inexplicable, but yet that's how that person feels at the time that they are ill with that episode. And along with all of those symptoms, the low mood, the inability to enjoy oneself, the hopelessness, the helplessness, the feelings that life isn't worth living, there were also all these physical symptoms, like muscle tension and symptoms that in fact overlap with Parkinson's itself, slowness of movement, slowness of thinking, and the fatigue and loss of energy. So it can be confusing when someone has Parkinson's to think, well, what is this? Oh, this is just my Parkinson's. But when someone is describing the lack of pleasure that and other symptoms as Israel described, it's important to see those are not. Those are part of a mood disorder that we need to look at and address specifically. And the hopelessness, the helplessness, and the thoughts that life are not worth living are very, very serious symptoms that are life-threatening and that need to be addressed and need to be taken very seriously. And I think that would be the most important point to underscore. Depression is associated with suicidality and completed suicides, and it's a real risk factor. Depression is a life-threatening condition that we need to take very seriously and treat. I think we'll talk more about treatment and what to do when someone has thoughts that life isn't worth living and how we can address that.
We will. We'll get to that in just a moment. But I'm going to move us along to our next slide and ask Dr. Pontone to talk a little bit more about why it is that these symptoms that we saw in the previous slide and that Israel describes in such vivid and personal terms take place. We've already made the point that this is not just about feeling down because you got this diagnosis or anxious because you're worried about the future after getting this diagnosis. This is also about something that's going on inside the brain itself and maybe going on well before the actual diagnosis that takes place. So Dr. Pontone, talk to us a little bit about this. We see that Parkinson's impacts not only dopamine, which is well known, but some of these other neurotransmitters as well. What's going on here that plays a role in creating those symptoms that Israel was describing?
Yeah, so I think the issue is globally one of mood regulation. We want people ideally to be able to experience the full range of human emotion so that when something sad happens, they can experience grief, but then return to a normal mood. When something happy occurs, they can experience pleasure and the good feelings associated with that event, and but not stay in that elated state for an extended period of time. And so I think what happens is when moods are disordered, there's a dysregulation of these brain chemicals, and people become stuck in one state or another. Usually, in this case, we're talking about the depressed state. And no matter what they do, and I think this is one of the things that Israel did a really good job of describing, is it didn't seem to matter what he did. He couldn't pull himself out of this mood state. So he did things that were normally pleasurable to him or that cheered him up, and yet he stayed stuck in that depressed state. And until you intervene to correct these imbalances of the dopamine, serotonin, and norepinephrine, it's really hard to get out of that depressed state of mind. And it's not for lack of trying, it's not that people are lazy. It's literally that without medical attention, they won't be able to rebound into a normal mood state. And when you're like that, you don't always have good insight and you don't think clearly. And I think Dr. Marsh made the point that the suicidal thoughts, even when they seem foreign, aren't something that you can drive from your mind. Once they start to occur, they sort of stay there and then take on a life of their own. And that's probably one of the most dangerous aspects of depression. These chemicals take time to change even once medication is started. And so that's another reason why you want to bring this to medical attention so that you can not only be put on the proper medication but be monitored so that any worsening of these symptoms can be brought to the appropriate attention and that things can be done to keep the person safe.
There's an audience question that I think is relevant here that I want to raise. And by the way, we understand that there are some audio difficulties with our webinar feed today, which we apologize for. Hopefully, once this is archived and people are able to replay it, all of that will be taken care of. But we do have some questions that were submitted in advance. And one of them, Dr. Pontone, that I think is relevant to this conversation that we're having right now, is one person wrote in, how can I be sure that the depression I'm experiencing is from Parkinson's disease versus some other cause? It's a really interesting question. Can we tell? And I guess as important, does it matter? You were just saying we need to treat these deficits or that may be occurring or abnormalities that may be occurring with some of these neurotransmitter deficiencies. So does the cause, whether it's Parkinson's or something else, matter, or is depression treated in the same way regardless of whether or not Parkinson's is the cause?
Well, that's a good question, and what I would say is it's going to be very difficult to tell, but one thing that's been observed that I think is relevant to whether or not it's related to Parkinson's is that even with good standard of care treatment for depression and Parkinson's, some people either fail to respond or are slow to respond until their motor function and the treatments for their Parkinson's motor symptoms are optimized. And so clearly, an association with Parkinson's can be important to treatment response. But in terms of is the depression that's experienced in Parkinson's different qualitatively than the depression experienced by people who do not have Parkinson's, right now, with a few exceptions, it looks like it's very similar in terms of the experience of depression. And Sergio Starkstein actually published a paper that looked at this, differences between the symptoms of depression and Parkinson's compared to the general population. The exceptions are that there tends to be more anxiety comorbid with the depression, and then that treatment difference where you really want to make sure that the motor symptoms are optimized to the greatest extent possible when you're pursuing depression treatment in Parkinson's, because if you're inadequately treated for the motor symptoms, it seems that it's harder to respond to the antidepressant treatment.
So in some ways, and let's look at this now to the question of treatment, and we'll bring Israel and Dr. Marsh back into our conversation. In some ways, there's sort of good news, I would think, to some extent in this, Dr. Marsh, that if depression in Parkinson's is quite similar to depression, generally speaking, that would seem to also open the door to the fact that the ways in which depression is treated in the general population with certain kinds of antidepressants that we see on the screen now can also be effective in Parkinson's disease. Is that right? What have we learned so far about the way in which depression can be treated within Parkinson's disease with the standard kinds of antidepressants that are used more generally?
Well, absolutely. The treatments that we use for depression in general, we use for depression in Parkinson's disease. I look at it as a clinician. It's you treat depression like you would in any other individual, but then you have the tweaks of Parkinson's that you need to consider, and as well as the experience of Parkinson's that person, even when they get better. And depression is treatable. People remit. They don't have the symptoms of the illness. However, if they have Parkinson's, even when we treat the depression, they still have Parkinson's, and they're going to experience those symptoms. But what patients will tell us is that, they can cope with depression. They can cope with Parkinson's disease, but not when they're depressed. So the treatment of depression makes the whole experience of Parkinson's disease much better.
Sorry to interject, but I want to get Israel to chime in on the very point that you just made, because I think that's really key, Israel. Would you say that that's true for you, that as you found a successful treatment for your depression, that it makes being able to cope with the rest of Parkinson's disease an easier challenge to contend with?
Yes, absolutely. I agree totally with what Dr. Marsh is saying, because I was, as I'm thinking back to my treatment of depression, once the motor symptoms seemed under control, then I was able to focus on, okay, the issue with depression is still there. And when you spoke of tweaks being needed even after treating depression, that's exactly what happened to me about a year and a half ago. My tremor seemed to be worse. And so when I went in for my next visit, I said, I'm thinking I need to increase my Parkinson's medications. And my movement disorder specialist says, let's talk about this. What's going on? So I started sharing with him, and I said, these are some issues with depression that I'm dealing with. And he says, okay, let's take care of the depression. The other will fall into place. So he was not quick to say, let's just increase. He said, let's talk about how these things are interacting. And that was a huge learning experience for me, because I kept thinking, I've got to increase. There's nothing that I can do. I'm progressing. But yes, Dr. Marsh, that's a very good point. It does remit, and we have to be cognizant of that constantly, so that we know what to look for.
Well, this is a really important point that I think we should spend just a bit more time on, because it makes so clear, I think, the interconnection between all of this. Not only the symptoms, but if your one symptom is worsening motor in terms of a motor symptom, it may actually have more to do with something that's going on the mental health side of this equation, and vice versa. And it also brings up the question, Dr. Marsh, of how these medicines may interact, because that's something that also people are always concerned about. For a while, there was a good deal of concern, for example, about how antidepressants interacted with one particular very commonly used Parkinson's medication, rasagiline, brand name Azilect. Can you say a little bit more, Dr. Marsh, and then I want to get Dr. Pontone's thoughts on this too, about that interaction question and what you have to be concerned about when you're sort of making these adjustments and tweaks that Israel was describing?
Well, so the concern of with rasagiline and other MAO inhibitors is that you can have an interaction with the antidepressants, where you can then have other physical symptoms, elevated blood pressure, agitation, etc., that can be dangerous. However, the actual occurrence of those kinds of adverse interactions is more theoretical than actual, though one needs to be always mindful of them and take it into consideration and educate the patient about this possibility. The other kinds of medication sometimes is that the person needs to be looking at, are they taking other medicines that maybe affect cognition negatively? Is their blood pressure over controlled? You really have to look at the whole picture of all the medicines that the person's on, and is that Parkinson's regimen, if that depression were optimally treated, is that going to be really a good regimen for that person anyway? So there's a lot of juggling and looking at how that person is responding from the standpoint of the antidepressant to the mood symptoms. So is that hopelessness getting better? Is it lightening up? Are they experiencing more fun days than not? And if they're not, we need to focus on treating the depression. If the problem is one where they're still having, off symptoms in the morning and really not able to move, but their mood is good, then we need to work on the depression. We need to work on the Parkinson's.
Right. And so as we can tell, I think, Dr. Pontone, this is such a complex interaction and equation. Makes the point, among other things, that it's really important to talk with your movement disorder specialist about all the medication that you're taking, not just the Parkinsonian ones, or if you're having other problems associated with Parkinson's disease, like sometimes low blood pressure or neurological problems or any number of other things, that all of those things kind of can impact one or the other. So it's really important to talk about all of these things in combination. But Dr. Pontone, as you look at this list, the various kind of medications that can be tried, I don't want to take too long to describe each of them, but is there an order that you try them in? Do you try first, and then if that doesn't work, then another? Israel was describing that the initial ones he tried didn't work, a later one did. How do you kind of assess which ones to use, and do we know more about whether or not one in particular is the sort of drug of choice if you're dealing with problems of depression and anxiety?
Yes, so while they're all quite similar, there was a recent meta-analysis that basically looked at evidence from a number of studies of antidepressant treatment in Parkinson's by Boom-Sang et al. From the University of Maryland. And it turns out that a combination of sort of efficacy, meaning effectiveness for depression, and safety together, that the SSRIs are probably the first type of drug for depression to start with in Parkinson's. And usually, and this follows what we would do in the general population as well, you try one, you get it to a therapeutic dose, give it the standard 4 to 6 weeks to work on the depression. If that doesn't work, you'll usually try a sister drug in the same class, in that SSRI class, if the first one doesn't work or works incompletely. And then if you have 2 adequate trials and you still don't have resolution of the depression, then you would likely move to a different class of antidepressants. And I'll just give you a general outline of the rationale. So the SSRIs are selective serotonin reuptake inhibitors, and for the most part, they only modulate the activity of one neurochemical, brain chemical, involved in mood, and that's serotonin. As you move up the list here and you go to the serotonin and norepinephrine reuptake inhibitors, now you're modulating 2 brain chemicals, serotonin and norepinephrine. And if those aren't effective, then you would go to the tricyclics, and just like their name, tri, suggests, it's 3 brain chemicals. So now you have modulation of serotonin, norepinephrine, and dopamine. And so you can see that the spectrum of your intervention becomes broader as you go down the list. Now, there is a consequence to that broader approach, and that's as you go down that list, typically there's a greater risk of side effects, potentially, as you go to these other treatments. And so for the most part, that's why we start, because of the lower risk profile with the SSRIs, but they can be equally effective if you get them to the right dose.
And Israel, that was your experience in part, right? You tried various things, and it took going to one of the tricyclics before you found the appropriate relief. Is that correct?
Yes, that's correct. It was trial and error, and yes, exactly what Dr. Pontone says. It was trying to see if there was a change, and then the hardest part was not seeing a change and wanting so much for something to work so that the mood would be different. But yes, that's exactly what my situation was. So.
And before we continue our conversation, let me just make a quick kind of a note in terms of the audio difficulties we've been having. Our apologies for that. Apparently, they've now been rectified. So for those of you who are been struggling with that and are now just joining our conversation, know that the entire webinar will be archived. And so once that's complete and we're able to get that online, you'll be able to access the entire webinar and hear all of the conversation, not just the part from this point forward. So again, thanks for bearing with us, and hopefully that will all work well in the archived version. A couple of audience questions that were submitted before we got our audio problems rectified that I want to bring in at this point. And Dr. Marsh, maybe you can take this one first. Someone wrote in, do depression and anxiety put you more at risk for cognitive issues later on in the course of Parkinson's?
Well, that is a challenging question. We know that cognitive changes can occur in Parkinson's or can be evident in an individual even very early in the course of Parkinson's. We also know that depression and anxiety are associated with cognitive changes, cognitive difficulty. So a person with depression can have memory problems that improve when the depression is treated. But there can also be sometimes for example, in Alzheimer's disease, that sometimes it's that depressive episode is a sort of a harbinger of that condition. What my experience is in treating patients, rather because we can't predict the future exactly, but we do know that treating depression and treating anxiety and addressing those and managing those well is associated with improvement in overall function, including cognition. So, for example, when depression is treated, a person will think more quickly, and Israel described that. There's that slow processing that then improves as time goes on, and so I would say that in terms of overall prognosis of Parkinson, we don't know, but we do know that in the immediate term, if we can get depression and anxiety well managed, that the person does not experience those symptoms like they would were depression and anxiety not addressed.
Thank you. And a related question, Dr. Pontone, that I will give to you, which is someone wrote in, do antidepressants negate the effect of the drugs that I'm taking for the motor symptoms of the drugs, of the disease. So do antidepressants somehow have a negative effect on levodopa, carbidopa, or some of those? Because as we just heard, actually sounds like treating depression can help in terms of clarity of thinking, but is there a concern on the other side that these antidepressants will somehow not have a good effect on the other drugs that are used in Parkinson's?
No, they actually, there's no major contraindications to using them in combination. There was some concern that, for instance, the SSRIs and other similar drugs might worsen tremor in the people who experience tremor, but we think that that's not a major concern for the majority of people. In fact, if you talk about maybe not directly the effect of the drugs, but certainly we know that treating depression has actually been shown to correlate with improved motor function and day-to-day functioning in people, and that when you treat anxiety, for instance, we actually see people having a less frequent disturbance such as freezing, and sometimes even triggering, less likely to trigger off periods when you're more relaxed. So I think not only do they not really interfere, but they actually facilitate functional outcomes in Parkinson's.
Which sounds very much like part of what your experience has been, Israel, that treating depression and anxiety has allowed you to contend with the other symptoms of Parkinson's that much more effectively. Israel, a question for you that's come in, which is just asking you to describe a little bit more, if you would, what some of your initial symptoms of depression and anxiety were. I think part of what people are looking to try to understand is, what are the real signs here? What is a sign of something that means I really should go and try to get some help?
The outlook on life is something that I would first say to think about, because in your daily life, if in my instance, I was thinking, okay, is this something that's going to give me pleasure in what I do? Is it something that I've enjoyed prior to what I'm dealing with now? So when I was going deeper into the depression, as I mentioned, I described it as and I share with my family, I say I'm tired. But when I'm physically tired, I don't ever say it that way. I'm worn out, I'm worn down. But I noticed myself saying I'm tired, but tired for me means mentally tired, and just not being able to consider again, if I do this, will it matter? If I say this, will it make any difference? It's more of a constant thinking of how am I going to get anything accomplished if I can't figure out for myself if this is worth doing. And along with the anxiety, yes, right.
Sorry, I just was interested in knowing whether or not that fundamental sense of sort of, is it worthwhile for me to be here? Can I make a difference? Can I matter to others? Can I make a contribution? Once an effective level of treatment was found in your case in terms of treating the depression, did all of that change? Did you have then a keener and clearer sense that, yes, indeed, Israel Robledo can make a difference in the world? Because I happen to know that you do, but did that change in terms of how you felt?
Yes, it absolutely did. Looking back, the correlation between my involvement and as an advocate and my engagement on a higher level has gone hand in hand with my ability to have the depression not under control. I still have to keep an eye on it. I have to keep a close eye on it. But yes, with treatment, I would say that there is hope. Now, the one thing I do want to make sure to get across is, if one antidepressant doesn't work and you're still not feeling as you feel you should or as you did prior, please don't stop. There's hope for getting the results that we all need. There's no shame, there's no weakness in saying, I'm dealing with this and I need help. There's no shame in it, honestly. Because the other thing that I will share is, if I tell you that I've been dealing with an illness, what would you say? But if I told you I've been dealing with a mental illness, would that make a person think of me any differently? And sometimes that's where I think people think that a person dealing with a mental illness is less than, and it's not true.
Israel, thank you. Let's take up more of those topics. I know that this is something that you care about in particular, Dr. Marsh, that it's really important for all of us to educate ourselves about these symptoms and to seek treatment and to treat a mental health concern as actively and vigorously as we would, a disease that has more prominently physical symptoms. Say something more about that and about sometimes how in our culture we have to make sure that we address these things in just as vigorous and medical a way as we might a broken leg or whatever.
Right. In fact, that's often the analogy we make is if we saw someone on the street with a broken leg, we'd rush them to the hospital to get treated. We wouldn't say walk. And depression is just like that. Israel's described it so well in terms of how the mindset of someone who's depressed changes in profound ways from the illness state to when you are well with that normal range of human emotions. And it's also what makes it so rewarding to work with in psychiatry is because our patients actually, they get better. They get better and they function better. So treatment works, people recover, and yet the attitude about mental illnesses is often that, it is hopeless or that the person's at fault. And I think we just have to help people hear these descriptions such as Israel's where, it was his life hadn't changed in any way other than this medicine, and he improved in terms of how he lived his life. Now, we treat depression all the time with medications, but there's more than just the medications that help and assist. The support one gets, the education one gets about what's being treated, the skills one gets in terms of learning how to manage your Parkinson's and your depression. But when someone is in the depths of depression, it's very difficult for them to access those skills, to even see the support that's being provided, again, because of that world view that is, looking at the world through the mud-colored glasses, again, and so we want to make sure that it gets treated, and we have to emphasize how it's, this is a life-threatening condition that is a public health problem that affects so much of the population, that the world is a better place when depression is treated and anxiety disorders are treated.
Absolutely. And Dr. Pontone, Dr. Marsh mentioned that there are things in addition to these medications that we've been talking about that can be helpful in contending with depression. You see the word exercise on the screen. Comment, if you would, on that, and also a number of other people have written in today wondering if there are other things, non-pharmacological things that can be done, whether that has to do with nutrition or diet, but take up that other part of, I guess, the equation as far as how we treat these with non-pharmacological solutions. Exercise, are there things we can do with nutrition and so forth?
Mm-hmm. So one of the big ones, is the talk therapies, the cognitive behavioral therapy, obviously, interpersonal therapy, those have good evidence. But exercise, I think, actually has a special application in Parkinson's. And we know that in the general population, exercise has actually been demonstrated to be effective for improving depression. Now, those same studies have not yet been as conclusively conducted in Parkinson's, but there's no reason to believe that there wouldn't be a similar mood effect for exercise in Parkinson's. But in addition, we know that exercise actually probably modifies the disease course in Parkinson's, favorably modifies the disease course. So there's really a short and long-term benefit to exercise in Parkinson's. It'll probably help the mood as it does in the general population depression. And it will help the overall disease, both in terms of day-to-day symptoms, but also long-term progression. So I think exercise should be on the top of everyone's list. The other thing it does is it gets people out of the house. Depression tends to be a very isolating illness, and so exercise is just another reason to be out and about doing things and potentially having additional social interactions. Now, in the winter, even exercising in the house is still a good idea because it mobilizes you. Other treatments are things like just being social and engaged. That the social interaction, forces us to sort of be in a sort of verbal give and take that keeps your mind active. And there's a concept we call strokes, which is just a positive affect and mood that's associated with that verbal back and forth between people, being recognized, having your feelings and emotions, whether positive or negative, validated by the presence and attention of another person. And so, these things don't have to be elaborate. The point is that you remain engaged with the external environment.
Israel, I can think of few other people who are better examples of being engaged in all kinds of things, whether it's helping kids in Midland, Texas, or the work you do with Parkinson's. But comment also, if you would please, on this question that came in that I think you can probably respond to well, and the way in which engagement for you has made a difference, which is, this question is, there's a challenge sometimes for men in particular, perhaps older men even more so, in not really believing that depression is a medical issue and thinking of it more as a weakness. Can you describe how your own feelings about that and why it's important to view it in a medical way? And then if you would touch on the way in which becoming engaged more actively in both professionally and in your volunteer work has made a difference to you.
Yes, I think the stigma is the worst that we have, and the thought that perhaps weakness comes into play when someone is dealing with a mental illness. And like Dr. Marsh said, if you have a broken leg, you're not going to say shake it off and just go on your way. Similar to depression. Many times just expressing the fact that you're dealing with something does make a huge difference. And I agree with Dr. Pontone that social interaction, sometimes my family, I would remember the girls would say, Dad, let's go do this, or let's go this place or that place. And I'd say, no, just don't feel well, just don't, you go on. And they'd sit there and say, come on, let's go. Let's get you out of the house. That was one of the most beneficial things that they did for me through the years and through my episodes, because they weren't saying you have to do this. They would suggest, and then I'd say, it'll probably help. Once I got back, that was wonderful. I was able to enjoy myself and those types of things. So going to the second part of what you mentioned is the ability to live your life to the fullest does come into play when the symptoms are under control. You have a something that you're focused on. I've always said to be of service to others is why I do what I do. At the same time, it's allowing me to see what's being done in research in Parkinson's and to know that there's hope in the future for new therapies and things that will help me. So it's a win-win in so many ways.
Let's spend the last few moments of our webinar just trying to take up some of the other questions that are coming in and picking up on some of the issues that have already been raised. Dr. Marsh, one person writes in saying, which drugs treat depression and which ones treat anxiety, or are they the same drugs?
Well, that's actually an area that Dr. Pontone is studying specifically, but many of the medicines that we use to treat depression also affect anxiety and can be used for anxiety. So, for example, in panic disorder, there is a behavioral component to the experience of anxiety. There's also behaviors that go along with depression, like staying isolated versus getting out and socializing. But in anxiety in particular, there's the feature of avoidance that is a behavior that we do. And a lot of the behavioral therapies for anxiety are really critical for getting past the experience of that illness. So if you're anxious about something, the best way to control that anxiety is to avoid what it is that's making you anxious. So if you're anxious about falling, well, just stay seated because then you won't have to worry about falling. So the behavioral treatments in anxiety help one maintain or control that anxiety experience while you're actually getting up and walking or doing whatever you're avoiding. So the medicines won't help that so much. So that's one. The medicines that are also used to treat anxiety, such as the benzodiazepines, Valium or Xanax, those are not antidepressants, and they won't help depression whatsoever. They do help anxiety in the short term, and sometimes for some individuals, in order to get out of a very intense state of anxiety, they can be necessary. But in general, we avoid using those because they can also have negative side effects, whether that's or negative consequences such as dependence, as well as increased anxiety, cognitive impairment, risk of falls, etc. So they are different, and it's a matter of identifying whether the person has a depressive episode that needs treated in addition to the anxiety, and which would lean us more towards starting an antidepressant versus with anxiety. We might start with behavioral approaches first, and then go from there, just based on how severe that anxiety is.
Dr. Pontone, I put the medication list back up on the screen so that people could review that. Anything else that you want to add in terms of differences in drug treatment approaches with depression versus anxiety?
Yeah, I just want to reinforce what Dr. Marsh said. While there is quite a bit of overlap, there are a few subtle differences. So the antidepressants are often used for the long-term management of anxiety disorders. They're used typically at the same doses we'd use for depression, and they typically take the same amount of time to work that the antidepressants do for depression. The one difference that's a little tricky is that often when you start an antidepressant to treat an anxiety disorder, for the first few weeks, the patient will actually experience an increase in anxiety that can be very problematic, especially if the patient is the first time you're working with the patient, because they think, boy, I came to you to treat anxiety and you've made it worse. And so sometimes those benzodiazepine drugs are used for the first couple of weeks to bridge that period of worsening anxiety until the antidepressant can really start to work on the anxiety, which may be delayed by 2 to 3 to 4 to 5 weeks, depending on the individual. But ultimately, these antidepressants, even though they're called antidepressants, can be equally effective for certain anxiety disorders.
Thank you. I just want to touch on one thing we haven't gotten to yet before we wrap up our situation today. And Dr. Pontone, why don't you just stay with this, which is whether or not there are new things on the horizon in terms of either new drugs or new approaches that we should keep our eye on as people who may be contending with this condition. Are there things out there that may be out there soon that will be helpful to people?
Absolutely. I think there's many reasons to be hopeful, and I think that even within our lifetimes, there's going to be a palette of new treatment options for depression and anxiety. One of the most exciting areas of new treatment is what we call the brain stimulation treatments. And that really ranges from the more invasive type of treatments like deep brain stimulation, which is right now primarily used to help the movement symptoms, but there's already a pretty extensive exploration into using DBS for mood disorders, both within Parkinson's and in the general population. So I think that might be an opportunity for people with Parkinson's especially, where you could get motor improvement from the deep brain stimulation and maybe mood improvement as well. Another type of brain stimulation that is not as invasive is the transcranial direct current stimulation that, again, may have both motor benefit and mood benefit, and we've actually just started a trial here at Hopkins for that with Dr. Salampour and Dr. Kelly Mills. We enrolled our first patient this week, and we're treating her depression with this intervention. Another sister intervention that uses magnetic field rather than direct electric current is called RTMS. And that, again, is not invasive. It's basically holding a magnetic coil near the brain and stimulating that way. And that's already been shown to be effective both in Parkinson's and in the general population for depression. So I definitely think that there's reason to be very hopeful and that we'll have a number of new treatments that will be very mainstream, I think, within just the next couple of years, hopefully.
That's really positive news. And I would encourage people that to keep tuned to the Michael J. Fox Foundation website for blog posts on all of these developments in research. We try to do the best we can, and I think do very well with posting updates about new developments in research, including these. So we'll continue to do that as some of these new ideas that Dr. Pontone was describing come to fruition. Unfortunately, we've reached the end of our session, our today's webinar, but before we close, I really want to give Israel Robledo, whose comments have been so instructive, I think, throughout the hour today, a chance to just kind of sum things up, if you would, Israel, please, about the importance of contending with this condition and your words or thoughts to someone who may be listening today or who has a loved one who is contending with this about the first step forward you can take to begin to contend with this important issue.
What I would say is be honest about what you're experiencing, and as a loved one, as a caregiver or someone, not to try to fix that person, because we have a lot of very caring people within our communities, but be supportive of what they're dealing with as a caregiver, as a family member. But as a person living with depression, what I would say is find the help that you need, because there is hope in symptom relief, and just don't give up. It's easier said than done, but don't give up on trying to find the best quality of life possible. And that pretty much sums up what I would say is just don't give up.
Israel Robledo, thank you so much. Thanks for your participation and your hopeful and helpful comments throughout our hour today. I also want to thank Dr. Laura Marsh and Dr. Gregory Pontone for their participation as well. We'll be sending a link to the webinar on demand for all of you to listen again. We know that may be especially important this time since we had audio difficulties in the first half of our webinar. So look for that link so that you can listen to the program in its entirety and also share it with others. There will also be a survey link in that email in your resources box, so that we'd like to hear your thoughts on today's discussion so that we can continue to fine-tune and improve our webinars going forward. And then please mark your calendar for our next Third Thursday webinar. That'll be on July 21st, when we'll be talking about some related issues, actually. We'll talk about pain and fatigue in Parkinson's disease. Until then, I'm Dave Iverson.